So, end of June. Anybody have any cool summer plans? Anything exciting? No? I'm gonna go to Yosemite next week. I'm kind of excited about that. But anyways, I muted myself. So I'm gonna just stop my video really quick. Well, I guess I'll leave it. I think it's fine over there on the side, but let me know if it's in the way of any of our, the slides. But so last month we started kind of talking about some of the extra cerebral physiological things that influence aEEG. And again, feel free to pop in the chat if you have a question or unmute yourself. Happy to answer those. And what I did was just kind of a quick review. So always think it's good to review, right? What are our 5 basic patterns? Our continuous normal voltage, discontinuous normal voltage, burst suppression, continuous low, or inactive. Reminding ourselves that when we look at these, we are always looking at these upper and lower margins. So for normal, looking for greater than 10 and greater than 5 for our upper and our lowers. For discontinuous, greater than 10 and less than 5. Burst suppression is our only one that's kind of that outlier where we expect those upper margins to be above 25, lower margins usually low and flat, less than 5. Low voltage, upper margin is the most important thing when it comes to this. So unlike the normal voltage patterns, the continuous and discontinuous, where the most important part is really that lower margin and that evolution of that lower margin up and above 5. With continuous low voltage, we're really looking at upper margin. So for the top 2 kind of our expected patterns, we're always looking at the lower margin, because that's really, remember that lower margin is really that indication of continuity. The more continuously active the brain, the higher the lower margin will be. And so that's really how we discriminate between continuous normal voltage and discontinuous normal voltage. Really that lower margin, which is really speaking to how continuously active the brain is. So then when we get to continuous, but it's always low voltage, this is where we're talking about upper margin. So the upper margin is not reaching 10. So again, I hope that helps kind of to distinguish between those. And then the other is just our flat trace, which is, you know, always going to be that low margin, both upper and lower margins, less than 5. So when do we expect to see them? Of course, our term babies is our continuous normal voltage. Discontinuous is that preterm or that sick baby. Burst suppression is those extremely, extremely preterm babies, you know, those 22, 23 weekers. Their brains are not really in burst suppression, but we call it a burst suppression-like pattern. But super sick babies, term babies. Continuous low voltage is for a very sick term or preterm, and then flat, of course, for our very, very sickest. So last month, we did start talking through some of the influences. So these are mostly, you know, other than maturational, which I think is cerebral, everything else is kind of extra cerebral. Things that either are happening to the baby or situations that are influencing cerebral function. So of course, maturation, you know, we've done previous calls just about maturation and prematurity, and we know that, again, the continuity increases as babies get older, so that bottom margin increases. Last month, so in May, if you go back to that recording, we talked only about the medications, and then we stopped there, and I promised that this month we would go through metabolic and then some of the other kind of medical emergencies and complications that we see that also influence the aEEG and can, if you use it, also influence the NIRS readings as well. So we didn't talk so much about that, but certainly I'm intending to include more and more of that with my discussions. So metabolic disease. So Christine Theta was is still a neonatologist. I'm not sure where she's practicing anymore, but Christine Theta was a neonatologist, and she worked at Bayside, Johns Hopkins, and she was also a medical geneticist. And so she had a real interest very early on, and the citation is there at the bottom of your paper. So 2010, she actually was looking at aEEG and metabolic disease, because she, as a geneticist and a neonatologist, had a huge interest in this. And what she found in this paper, and it's a great review of looking at babies with inborn errors of metabolism. She also published another paper, which if you haven't seen it, is another great review, where she actually at one of the brain conferences that we used to have, that's actually coming up in February of 2019, the International Brain Monitoring and Neuroprotection. She presented one year, and she asked everybody, if you have a metabolic baby that you monitor, let's do like a consortium and pull those together, because they're so rare in our individual units. And so she actually made out a call for that. And I think between that meeting and maybe 2 years later, she had like 24 different cases, and they wrote a paper as a group. And that's another paper if you haven't seen it. It was really, it was an international contribution. It was really a great paper. But what she's found, so long story to get to the basic point, is that regardless of the cause of metabolic disorder, so whether it's acid base, whether it's electrolyte, whether it's amino acids, or just urea cycle problems, it didn't really matter what the cause was. It almost always caused a non-specific depression in cortical activity. And this was really a reflection, and makes perfect sense, right, of a diffuse cerebral injury. So these situations, these metabolic situations, are causing these kind of just overall just sick brain, which causes this overall depression of activity, much matching the presentation of the baby, right? So if you think about these metabolic babies as they present, if they're undiagnosed or late diagnosis in that first week of life, they begin to come in and they're just floppy and they're encephalopathic, and they're almost always just really that low activity. So this depression of cortical activity goes along perfectly with that. So the other thing that these babies oftentimes have that we know are seizures. And so this again was from her paper in 2010, just showing these very extreme high voltage seizures and just recurrent repetitive status epilepticus, which we also know is oftentimes a feature or a presenting clinical finding for these babies. So you can see here, this is marked with the A, where the baby's having these short seizures, these quick uprisings, not as well defined to begin, but definitely some rhythmic spiky stuff. And then here at B, look at this very long, almost 30 minutes, right? So if it starts here, 10, 20, oh yeah, almost, well, at least 25 minutes of this long uprising, and then looking in here and seeing this very classic spike wave pattern. So this particular paper by Christine is just really well done. I encourage you, if you haven't seen it, to go back and to consider it, and just some great case studies in there as well. So the thing that she also remarked on were that the aEEG can be used as an objective marker for the effectiveness of our interventions. So as we begin to treat these patients and help them to remedy and reverse their metabolic dysfunction, that the aEEG will improve. And sometimes the aEEG will improve even before the baby starts to kind of perk up. And as you can see here, I'm a very sick baby, and I don't know about you, but sometimes these babies come in and they do feel like the sickest babies in the units. Another metabolic situation that is getting more and more attention is hyperbiliry. And of course, we are definitely wanting to manage hyperbiliry, especially high levels of hyperbiliry. And many people are using, actually, those of us that were working at Stanford right now, we actually are looking, we've put it into our top 10 list, is babies who come in the 95th percentile or higher. We are doing aEEG on those babies as a screening, just to be looking at what's going on. And so there are several different papers out there that are looking at hyperbiliry. I hadn't used it in the past as kind of a general baseline. I'd used it in the past when babies with hyperbiliry would come in with funny movements, either just funny posturing, and I couldn't tell if it was just related to the hyperbiliry or did they have something else going on, right? Infectious or meningitic. And so I had used it in the past to rule out seizures, and not really thinking about it so much as just kind of neuronal dysfunction and depression. But basically, some of these papers are showing that there are some changes, up to 20% decrease in amplitude without clinical symptoms, and that there is a delay in maturation as well. So interesting that the bilirubin we know it can be toxic and it can cause injury, but interesting to think of it, I guess, in this way as well. So 2011, Liu described 10 babies with acute bilirubinencephalopathy. This is in China, where they have a huge issue with that due to some of their genetic issues and, well, I guess, or genetic predisposition, but abnormal EEG in many of them, and 80% of them had seizures. So again, just this very large percentage with seizures. And then 2017, Dr. Zhang, another physician from a different hospital in China, found that 50% of babies with hyperbili have disrupted sleep-wake cycling, which is interesting as well. If we think about back to some of the talks we've had before about sleep-wake cycling and the importance of sleep, you know, it's interesting, right? Because if you think about those term hyperbili babies who come in and, you know, have been at home maybe and then are readmitted, I mean, they really do have a difficult time sleeping, right? They're either irritable and cranky, or they're just so lethargic that they're just not able to eat. So it is interesting to note that aEEG picked up this kind of disruption in sleep-wake cycling, which I thought was kind of interesting. Another metabolic situation that we encounter a lot in our NICUs, right, is hypoglycemia. And seizures, obviously due to hypoglycemia, don't have really a specific EEG pattern. So there's not a specific morphology when we look at that, but certainly we know that hypoglycemia, it's a hot topic, right? And we wonder if babies are not having more transient hypoglycemia than we know. And I just recently heard that Sick Kids in Toronto is actually doing continuous EEG, aEEG, along with some continuous blood glucose monitoring, which I find very interesting. I think that it's going to be exciting work when they publish that, so that we can begin to see what's actually going on. So this is in international units. So for those of you watching from international units, you'll know what this means. But basically, lower numbers are bad, right? So just like with our milligrams per deciliter. So you can see here, this aEEG is pretty suppressed. And then you can see these lower values, so 1.4. And this is an old paper. I think this is from, I think I have the citation at the bottom. But you can see it's just the old paper, the paper one. So kind of this low, flat tracing, so that the continuous low voltage, and then starting to see some disruption. So, you know, the value was 1.4 and dropped to 0.2, very low values. And you can see here these little uprisings, potentially seizures, difficult to know unless we see it. But here, look at this amazing increase. And you can see the bottom margin kind of moving upwards. And this is all after the blood glucose had been corrected. So this was a 38-weeker, 4 days of life. So this isn't even a preemie. So this is a near-term baby and 4 days of life. So right here, improved. And then another one, let me move this band in case it's in front of the way. So kind of a, you know, not a super great tracing, but then look at here when it drops to 0.6. Again, very low values, and then almost a completely suppressed flat trace, and then some correction there. So this is from Lena Hellstrom-West, just 1989. This is with the old cerebral function monitors, the electromeds that they did. So just interesting to see some of those. Another metabolic feature that I think is really important, this is from Frank Van Bell from the Brain Monitoring Conference in 2015. Probably all of you have seen this. So he's looking more at NIRS and looking at some of those situations. And looking here, we've got the pulse ox here. The blue is the cerebral NIRS. So as a reminder, the NIRS is just that end organ saturation. It's a mixed saturation. So your pulse ox is going to be arterial. Your cerebral NIRS is a mixture of cerebral and venous blood. So it can reflect perfusion. It can reflect also oxygenation status, and extraction, oxygen extraction and utilization. The red line here is the mean blood pressure going along. And then the PCO2s are the little brown dots. And you can see, look how low the PCO2s are here. Our pulse ox is showing fantastic, which is one of the things why we need these other end organ. You'll see here that the blue line is very low. And just as a reminder for cerebral saturations, we want them somewhere between 60 and 80, and below 50 is kind of that cutoff of danger. So we like them, again, 60 to 80. Not that higher is better, but just kind of in that range. So you'll see that as the PCO2s are really low, look how low the cerebral sats are. So we know what a powerful influence, I guess I'll say, CO2 is on our brain perfusion. And so as these CO2s, this hypocarbia being so low, then causing our cerebral sats to be so low. And then once these are corrected back into that almost normal range, we see that they correct. And so just what a powerful, powerful thing. And many of our monitors now kind of showing this multimodal approach where we can see the NIRS, the aEEG, and see the physiologic as well. So super important to see all these together. This is another great paper by Dr. Shawnee's group from Israel. And this is looking at a small baby, 24 weekers, 2 days of age. And so if we could almost imagine the baby we just looked at, and the same similar, CO2s, actually this is reverse, these hypercarbia, right? So we are seeing this huge amounts of overperfusion and just the brain basically shutting down here. And you can see this, and then an improvement once we correct the blood gas. So just again, remembering that the function of the brain is so dependent on, these metabolic factors that, when we look at aEEG, there's maybe more under the surface than just the pattern itself, thinking about all these influences that really exist. Oh, where are the other slides? I guess we can just pause there, and we'll have to do medical complications next time. I'm not sure where the other slides went. But any questions or comments about those? I guess the metabolic situations. And does anybody have any experience with that, or anything they want to chat about? The quiet group today. Doing good. So have some of you encountered these kinds of patients before? And have you monitored them? Have you been monitoring them? Does this kind of open your eyes to maybe some different populations even? If you haven't been monitoring these babies, I'd invite you to maybe consider, bringing these up to your group and to think about, again, this is really about getting beyond just cooling, right? I mean, it's obvious we need to be doing brain monitoring during cooling and for HIE, but there's so many other applications for aEEG that I think really begin to paint a much bigger picture for us. So, well, if you don't have any questions, you all know how to reach me. Please feel free at any time to reach out, and I'm always here to help and support you guys. Looks like there's a little chat. Great. No, I love this. So Carol's just saying, trying to get her docs interested in other applications than cooling. So great. Well, I hope this is helpful. Again, any of the kind of those 4 reasons we've been talking about, but I think this is one that goes missed a little bit, and certainly can help paint the picture, especially when you can layer the aEEG, your NIRS, and your physiologic information together. It's helping to almost see the baby in 4 dimensions that way. So I love that. Thanks, Carol, for mentioning that. But, well, all right, guys. Well, our next call, as you can see on the screen, will be on Monday, July 23rd. I will actually be in Knoxville, Tennessee that day. So hopefully my internet is working fantastic. And Anyways, so great to see you, and thanks for joining. And just keep the discussions going. We'll be over on Synapse Care for those. So anyways, talk to you guys later. Have a great summer, and talk to you next time.